So this is just a brief video looking at some of our proposed inverse care project on Anglesey. Now, what we're looking for really is blood pressure as an indicator of management of chronic disease and population screening. And one of the things you can do inside EMIS is you can make searches based on Townsend scores, which are primarily, in EMIS at least, based on postcode, so that we can identify those who are eligible for a blood pressure check, and we can look to see who has had their blood pressure checked in the last year and who hasn't, and we can then see how does that compare by Townsend score. So if you are below 0, which is usually a sign of increasing deprivation, so the more negative your score is, the more likely it is that you live in a deprived area or postcode, and then if you're above 0, it's the other way. And we see here, for example, for my population so far, that in my screening group, this is the 5-yearly eligible, so these are people who just need a blood pressure of 5 years because they're over 50, which was the old QOF standard. It's changed slightly in England, I know, that of our 1,500, about 1,200 of our population have a Townsend score below 0, as in lesser affluence, and of those we've had 760 done, so about 60% of that patient group done. In the higher Townsend, above 0, we've had about 67% done. Now, which suggests that slightly we've got more people from more affluent groups have had their screening blood pressure, although the difference is not large. And the goal will be to do this across enough practices to try and see if there is anything that shows any statistical significance. We know we can look at the yearly group, and it's the other way around here for me, so that in my deprived groups, of the 1,400 that are eligible for yearly blood test, we've done 56% of them in the last year. In the more affluent, of the 500 eligible, we've only managed to hit 52%. So overall, when we do it all like for like, we're neutral. We don't seem to be biased one way, or there's no sort of strong correlation at the moment. But blood pressure is quite an important feature in our year of care work. So some of this was born of post-COVID work showing that we were quite behind with blood pressure capture in our most at risk and blood pressure screening for our over 50s. And so if you're due a blood pressure and blood test, you'll be in this HCA group. We know we've got people who don't really need any blood tests, but we just need their blood pressure doing. So in my practice, I have 750 patients at the moment who either need a yearly blood pressure or a 5-yearly blood pressure, where we should be ideally bringing them in to have their blood pressure checked. But I know they don't need a blood test, so these are a group where I would be considering having them either monitor their own blood pressure, send people kits, or ask them to go to leisure centres or chemists or opticians or any waiting rooms in our surgeries with automated machines, and just give us their blood pressure, and then we decide from that group who might need average blood pressure monitoring and further investigation. We can also slightly modify that group into the higher priority group. So for example, here we can decide that, right, we want to prioritize certain individuals at the moment, so we can prioritize people who haven't had a blood pressure, are eligible for blood pressure, where the last blood pressure was over 150 over 90, so their last blood pressure was raised, and have a Townsend score of under -2, so they're in increasingly more deprived indices. It's just a suggested priority, and of course we could adjust that. So if we did get some national guidance on, hey, we'd like you to try and target these groups first, then it may allow us to be a little more targeted if we don't feel we've got the capacity to try and catch up the sort of workload that has been impacted by COVID and pandemic and changes in contract. Now, the all group in my year of care shows patients. This is a snapshot of my whole patient population. We clearly can't do everything at once, which is why I suggested we split things into month of birth. If you watch some of the other videos, enhanced service work or work where there's targets needed for certain shorter timeframes and timescales, they'll get called in when needed. But if you have a routine process, blood test, blood pressure, you would get called in the month of your birth. So if you need your blood pressure and you're not in enhanced service or high risk, you'd be invited in May because you're born in May. Now, people coming in to see the healthcare assistant phlebotomist, if you use the HCA template, I know that if they do a blood pressure, and many of them will be, it'll be one of the processes that'll be there on that template for capture. But I know that I've got 75 patients born in May who don't need a blood test. I still perhaps want their weight, their smoking status, their alcohol intake, so that we can offer them advice on those unhealthy behaviours. But they don't necessarily need to be brought in to see somebody. These are all things where if we can get their blood pressure done either at home or elsewhere, then we can also get the other data from them in a variety of different ways. And we don't need to bring them in for appointments. Again, we can have higher priority groups. So this is based on that search looking at people whose last blood pressure was raised or that have postcodes with more negative Townsend scores. If we wanted to. The other search here looks for our patients where the last blood pressure was done in the last year, was raised, and it's been more than 3 months. So say, for example, if they had been, because they were born in November, invited in November for a blood pressure check, it was raised. The hope then is that we've either done average blood pressures or titrated medications. This is split into a few groups here. These are people where they're already on treatments of some sort for blood pressure or have a chronic disease where we would want to be managing them more aggressively. And then patients who ideally perhaps should have had average blood pressure done already, and these are patients whose last blood pressure reading was raised, they're not on medications, they're not in a chronic disease group. We should be trying to target them for home blood pressure monitoring. Now, this is mainly because we noticed a tendency to measure a blood pressure, see that it's slightly borderline, suggest that we repeat it again in a few months or ask patients to give us home blood pressure monitoring readings, and they were forever lost to follow up until perhaps a year or two down the line when it's done instantly or they were caught next year. So it's really to try and make sure that when we do find a raised reading that we are following up. We want to make sure that when we are inviting or offering screening that we code that that's been done. And so the code that I propose using is the 90E1 code. The idea behind that is we can then look to see who isn't responding and send another invite, and then we can look to see who hasn't responded to 2 invites. The principle here is that we also want to try and identify areas where perhaps there is deprivation and there is poor response to invites. So if I go into the Inverse Care Project work, it will show here patients who are non-responders. Now, we haven't been using this yet. We have issues in practice around capacity and ability to do some of this catch-up work and ability to chase patients, and we are looking at cluster support and health support, transitional support for that. But the goal will be to identify either individual practices where low Townsend score areas seem to have a high rate of non-responders or low rates of invites. We want to try and then look at, is there support in those areas to try and make sure that we are capturing this population. The reason we went for blood pressure is it's canary in the coal mine. If you imagine that people with chronic diseases haven't had their blood pressure, we'd argue that they may well not have had a proper review of the rest of their processes. And also, of course, it's linked with significant endpoints around stroke and heart disease and kidney problems and dementia and all these things and vascular problems. So I think it's a nice important one. I think there's a national goal to try and improve our targeting of patients, our following up to make sure that we're aggressively getting them to target.